Hello, welcome to today's presentation on the use of laparoscopy in trauma. My name is Nathaniel McQuay Jr., and I will be presenting on the question of when is it safe to be less than maximally invasive in abdominal trauma. I would like to thank the committee for the opportunity to present. I have no disclosures. Three types of laparoscopy are defined on this chart: as a screening tool, a diagnostic tool, and as an increasingly utilized therapeutic modality. Today's presentation will focus more on the role of laparoscopy as a therapeutic modality, as this role is historically less defined. Since the first published report on the use of laparoscopy in trauma in 1925, there has been an increase in the number of publications with each subsequent decade. This graph demonstrates not only the increase in publications, but also the change in the types of laparoscopy studied over the 90-year time period. Prior to 1990, the role of screening and diagnostic laparoscopy were investigated. It is not until 1990 that we begin to see studies describing therapeutic laparoscopy for the definitive management of intra-abdominal injuries. This systematic review, published in 2013, looks at the role of laparoscopy in penetrating abdominal trauma. It includes 51 studies totaling 2,569 patients. 20 of the studies report on therapeutic laparoscopy in 1,986 patients. Publication time is from 1993 to 2011. 1,277 diagnostic laparoscopies were performed. Of these, 597 were positive for injuries, of which 145 therapeutic laparoscopies were performed. This chart reports the visceral injuries that were managed at therapeutic laparoscopy. The most common procedure performed was diaphragmatic repair, followed by the management of hollow viscous injuries. There were 29 deaths in the therapeutic laparoscopy group and 22 missed injuries. Of all 51 studies, total missed injuries numbered 82. The authors concluded that both screening and diagnostic laparoscopy use were safe in the management of abdominal trauma. However, its therapeutic role was in question due to concerns for missed injuries. They recommended higher quality studies be performed comparing therapeutic laparoscopy to the standard open laparotomy. They also concluded laparoscopy was safe to perform in the absence of contraindications to include hemodynamic lability, severe head injury, and retroperitoneal injuries. Surgical innovations improve over time due to advancements in technology and technique. This graph demonstrates this concept with laparoscopy located in the center. Along with its advancements, there is further development of the operator's skill set over time. If this concept is applied to the use of laparoscopy in the management of penetrating abdominal trauma, improved outcomes should result. This more current comparative study investigates the role of therapeutic laparoscopy in the management of abdominal trauma by surgeons with advanced laparoscopic skills. The study period is from 2004 to 2014 with 25 patients in each group. Perioperative outcomes were compared. The groups were similar in terms of age, sex, ISS, and systolic blood pressure. This chart lists the injuries managed in both groups. The most common injury managed in both groups were hollow viscous injuries. Operating times were similar between the two groups. Opiate use, complications, and hospital length of stay were shorter in the laparoscopy group compared to the open laparotomy group. A 0% missed injury rate in the therapeutic laparoscopy group is reported. This 2010 multi-institutional study compares outcomes of patients with abdominal trauma managed by therapeutic laparoscopy to those managed with open laparotomy. Study period is from 2013 to 2017, with 54 patients in each group. The majority suffering penetrating trauma, and again, perioperative outcomes were compared. Both groups were similar in age, sex, ISS, and systolic blood pressure. This chart compares the injuries managed in both groups, with the only difference in spleen injuries being more commonly managed in the laparotomy group. Again, we see the most common injuries managed between the two groups were those of hollow viscous injury. Operating time and complications were similar between the two groups. There was less opiate use in the laparoscopy group and a shorter hospital stay in the laparoscopy group. Again, 0% missed injury rate is reported in the therapeutic laparoscopy group. In 2015, Safar et al. Queried the National Trauma Data Bank to evaluate the realm of therapeutic laparoscopy in the management of abdominal trauma in the United States. Study period is from 2007 to 2010, with 4,755 patients identified from 467 centers. Patients undergoing diagnostic laparoscopy were identified, and from this group, patients undergoing therapeutic laparoscopy were identified. These were compared to like patients who underwent open laparotomy. Again, we see that the most common injury managed in this population was hollow viscous injuries, totaling 32% of the population. Mortality was similar between the two groups, with a shorter median length of hospital stay in the therapeutic laparoscopy group. 0.5% missed injury rate in the therapeutic laparoscopy group is reported. In 2010, the Eastern Association for the Surgery of Trauma put forth guidelines for the non-operative management of penetrating abdominal trauma. They recommended that diagnostic laparoscopy be considered when evaluating for diaphragmatic injuries as well as for peritoneal penetration. They also recommended the use of diagnostic laparoscopy to identify hollow viscous injuries not be utilized at the present time due to the concerns for missed injuries. Concurrently, guidelines from the Society of American Gastroenterology and Endoscopic Surgeons were put forth on the same subject. Recommendations were similar in terms of identifying diaphragmatic injuries as well as ruling out anterior fascial penetration of the abdomen. However, they recommended that therapeutic interventions can be provided safely when laparoscopic expertise is available. Currently, the Eastern Association for the Surgery of Trauma is updating its guidelines for laparoscopy in penetrating trauma to more represent the more recent therapeutic role of laparoscopy. So in summary, when answering the question, when is it safe to use laparoscopy in penetrating abdominal trauma, the following recommendations are included in the recommended guidelines. In the absence of contraindications to include hemodynamic lability, severe head injuries, and retroperitoneal injuries. In the management of thoracoabdominal injuries to rule out diaphragmatic injury, and tangential injuries to rule out penetration of the anterior abdominal fascia. And in the settings where surgeons have advanced laparoscopic skills as well as adequate equipment and personnel, therapeutic laparoscopy has shown increase in safety and decrease in missed injury rates. I would like to again thank the program committee for the opportunity to speak, and thank you for your attention.